You're listening to Leverage.
To Leverage.
To Leverage.
An ASA Studios production.
Welcome to Leverage, ASA's podcast covering the politics of aging. I'm Amy Herr, ASA board member, co-chair of its Public Policy Committee, and Director of Health Policy at West Health. About a year ago, ASA and West Health released a special issue of Generations Journal on older adults and America's healthcare cost crisis. So much has changed since then, and the need to address healthcare costs has become more urgent than ever. Please join ASA and West Health as we talk healthcare policy and politics and get experts' ideas on the direction to take for better, more sustainable healthcare as we age.
Hello, I'm Leanne Clark-Shirley, VP at the American Society on Aging. This month on Leverage, we've been diving into America's healthcare cost crisis, what's driving those costs, and what we can do about it, particularly in the context of our aging society. Today, we're going to talk about models to disrupt one of the biggest cost drivers, that's hospitalizations, and how these innovative models not only address costs, but can also improve health outcomes. A large share of healthcare costs results from unplanned hospitalizations, many of which happen as a result of chronic diseases among older patients. On top of that, the risk of hospitalization for conditions like influenza and COVID-19 is much higher for older people. Before the pandemic, Medicare spending on hospitals was growing dramatically, up to $1.2 trillion in 2019. And now spending trends are a little more complicated due to the pandemic because hospitalizations for non-COVID conditions fell fairly dramatically at the beginning. Yet there's a lot of concern about longer-term consequences and costs of delaying treatments that might lie ahead. But acute care doesn't necessarily need to happen at the hospital. Innovative models are successfully responding to unplanned acute health episodes among older people and interrupting care trajectories that typically lead to the hospital. Here to talk about these models is Dr. Bruce Leff, Professor of Medicine and Director of the Center for Transformative Geriatric Research at Johns Hopkins University School of Medicine in Baltimore, and Dr. Amy Stuck, Senior Director of Value-Based Acute Care at the West Health Institute in San Diego. Welcome to Leverage, Bruce and Amy. Thank you for being here.
Thank you.
Great to be here, Leanne. Thanks for having us.
Sure. So let's start at the beginning and talk for a few minutes about hospitalizations. What happens in a typical scenario when an older person has a health event, and why are hospitalizations so common in their healthcare trajectory, especially when they're so expensive? Amy, let's start with you.
Sure. Well, as you know, older adults have a higher burden of chronic disease, both in terms of the number and the severity of chronic conditions, and they're often frail and disabled. As a result, small destabilizing incidents can cascade into dangerous episodes of chronic disease exacerbations or episodes for which a visit to the ED followed by a hospitalization is typically the only available option. So the traditional pathway is that an acute event, medical event happens, and they call 911. They go to the emergency department, and then for Medicare patients especially, most get admitted to the hospital. And then this traditional care pathway has really important and unintended consequences for seniors related to their health outcomes, their experience of care, and their costs. So unfortunately, once they're in the hospital, seniors are particularly susceptible to hospital-acquired infections, delirium, functional decline, and these can lead to extended stays and dispositions to, say, skilled nursing facilities.
Sure.
And just to build on that, Leanne, I think one thing that's really important to think about is some people may be wondering, well, why is it that when an older person who has chronic illnesses, chronic conditions, and has symptoms start to flare up, like why don't they get to their primary care doctor? And, for the folks so first of all, our system is not easy to navigate.
Sure.
For anyone, but especially for older adults. The other is that I think sometimes people tend to forget is that if you're old and frail, getting out of the house is not easy. Mm-hmm. And, you have, depending on how you define it, you have probably somewhere between 2 and 7 million older adults who are either completely homebound or really have a lot of trouble getting out of the house without help from someone else. Yeah. And there's been there was a brilliant study that came out of Kaiser Permanente that showed among folks who they classified as frail elderly, 25% of those people, when they look back at their healthcare claims over the last year or so, had no primary care encounters.
Wow.
All of their encounters were with the hospital, with skilled nursing facilities, with skilled home health care. And, the inference that we draw from that is that, if you are functionally impaired, if you're functionally limited and home limited, and you cannot get to the doctor's office, your access to care comes through hospital.
Sure.
Through the ED, through the 911 system, as Amy laid out. And for people like that is, at some level, it's a tragedy because it's a really terrible way to access care. And you start this whole cascade of care and utilization where you go from hospital to skilled nursing facility, back to the hospital, back to skilled nursing, back to home health, back to the hospital, without anyone coordinating your care like a good primary care physician, either an internist or a geriatrician or someone else. Yeah. So it leads to this evil cascade of events and utilization that does not serve anyone well.
Sure. So what might an alternative trajectory look like? How can we disrupt this pathway that leads to the hospital and then spirals?
Yeah, so I think at a few levels, it's interesting to think about a health system that actually is more coordinated and logical for older adults, especially for our older adults. And then in terms of trying to interrupt the easy pathway, the established pathways of care, something that we started working on here in Baltimore at Hopkins in the mid-1990s, was to think about trying to provide acute hospital level care in someone's home as an alternative to doing it in the hospital. And we were motivated by our work in home-based primary care. So we have a home-based primary care program at Hopkins. And I started doing work in that as a resident back in the late 80s. And so this was a program where doctors go out to the home and provide ongoing longitudinal care in the home for people who are too frail to come to the typical clinic or the typical doctor's office. And what we found there was that when some of those people got acutely ill with things like heart attack or pneumonia or episodes of heart failure, they would often refuse to go to the hospital. And that was based on their prior experiences in the hospital, which were less than satisfactory.
Sure.
So, for them, the hospital is a bit of a lonely place.
Yeah.
They can develop, as Amy was talking about, episodes of confusion. If they were weak and not functioning, fully before, you get confined to a bed for a few days, you become more weak, and then you may need to go to a nursing home. Yeah. And then, from a geriatrician standpoint, so I'm a geriatrician, when my patients go into the hospital, we see the awful effects for some of being in the hospital. So as Amy mentioned, developing acute confusion or delirium, which can have long-term cognitive effects, becoming more functionally impaired, having adverse drug reactions, all of those things, sort of spirals into this cascade of hospital-associated hazards. So we thought, could we do acute hospital care in the home? And that was a model that we developed the theory for back in the mid-90s at Hopkins, did some early pilot work here in Baltimore. And then because there was no payment model for that care in typical fee-for-service Medicare, we did larger trials in Medicare managed care, Medicare Advantage plans, and then have been working over time to help disseminate the model into practice. And, we've had wonderful relationship with Amy and her colleagues at the West Health Institute to work on various aspects of making that happen. And we could talk about all of that.
Yeah, well, let's do that. So you mentioned acute hospital care at home. That's one of CMS's big initiatives. So Bruce, walk us through this model. How does it work? And why would someone choose that over a typical hospital stay?
Yeah, I think those are all great questions. So the model has evolved over time. In our original model, but much of it has stayed relatively constant. So in our original model, the idea was to take folks who are coming in and presenting usually at the hospital, at the emergency department, not always, but most of the time at the emergency department. So for someone who had a certain qualifying condition, and we started off with a small set of conditions, pneumonia, heart failure, things like that, but that has greatly expanded over time, and now many conditions can be treated in hospital at home. But someone with a qualifying condition, someone who meets the threshold for hospital care, which is really important, right? You don't want to throw more care at someone who could leave the emergency department with a prescription, say, for an oral antibiotic, who doesn't need IV antibiotics, or with recommendations to change the doses of their heart medicines instead of coming into the hospital to get IV medicines and multiple cardiology consults and testing. So they have to meet the criteria to gain hospital admission, and those criteria are things that we worked on to develop. And then, but they can't be so sick that they need the intensive care unit.
Got it.
Right. They can't be so sick that they're going to need a highly, highly technically oriented admission.
Sure.
And even that's gotten a little easier over time as the emergency department has become, in many ways, a one-stop shop major diagnostic center. Back in the early 90s, late 80s, the emergency departments were not functioning at the level they are now. And sometimes people would have to come into the hospital for the CAT scan, for the MRI, et cetera, et cetera. But now a lot of that can happen a whole lot more quickly. You can gain more diagnostic certainty in the emergency department, and it allows you to find the people to treat in hospital at home and understand that you're selecting the right patient.
Right.
That selection actually has also been influenced lately by the advent and the development of tech, right? So when we did our first hospital at home studies back in the mid 90s, the most sophisticated tech that we had, I had a beeper that was not even a pager that was not even a text pager. It just went beep, and you had to call the hospital operator to find out who called you. And the first generation cell phone, Leanne, which you look way too, you don't even know what those look like. I mean,
I do.
You need a kind of a small backpack with your phone. And that was the biggest, most tech that we have. But now, you have the advent of much more sophisticated remote patient monitoring. You have, the ability to do televideo visits. So you can look in on a patient at any moment, and you have the ability to do televisits with physicians or nurses or any other member of the team. So in our original model, we would take people, we would find our patients in the emergency room, we would tell them about this model. They said yes. They said, we would like to be taken care of at home. And I think for the people who say yes, they are choosing in their own minds, some of the research we've done, they're choosing the comfort and convenience of being cared for at home. Yeah. And they value that. The people who tend to say no tend to have a point of view that the hospital is intrinsically a safer, better place. And I think that's changed over the last year as people's attitudes toward facility-based care has changed.
Yeah, that makes sense.
But we take them home, and then you have to get things to the home quickly. So you get a nurse at home, you get the doctor visit at home, you get IV medications at home, you get oxygen delivered at home very quickly. All of those things the patient would need. They get followed at home. Initially in the model was daily physician visits, at least once or twice daily nurse visits. And then in the old days, we would be telephoning people. And now most of the programs are using a lot of telehealth components as well. Someone needs a physical therapist, occupational therapist, social worker, all those things can be brought to the home. You can do blood work at home. You can do x-rays at home. You can do ultrasounds at home. If someone needs a test that you can't do in the home, take them to the hospital, get the test done, go back home. Yeah. And you follow them through until you, quote unquote, discharge the patient from that acute care. And then some programs have also added a component of post-acute care where they will follow patients on a less intense basis at home to ensure that they don't need to be readmitted to the hospital, don't have to go to the emergency department. And the key thing, one of the key things that I don't think we talk about enough, and Amy, I'd love to hear your views on this, is the idea that by having someone at home, you have interrupted the usual glide path of care. So I can tell you, I just finished an inpatient attending stint about a week or so ago. And the glide path is older patient comes in, you treat the acute illness, inevitably you have to get, they need occupational therapy and physical therapy to evaluate them. Mm-hmm. Inevitably, the PT and the OT will say, patient should go to a skilled nursing facility. Mm-hmm. And then they go because that's the easiest path out of the hospital bed.
Yeah. Yeah.
And a lot of hospital at home studies have shown that you tend to cut readmission rates in half.
So we approached disrupting that trajectory from a little bit of a different angle. And when we started this work, probably about 5 or 6 years ago at West Health, and we have the dual mission, right, of lowering the cost of healthcare and successful aging. And when we started to look at that expensive trajectory, it led us to Bruce's work, which has been monumental of bringing that awareness and really implementation to hospital at home in the United States. But we were also, so that's one model, right? And we recognized very, very early that clinicians didn't have options other than the traditional trajectory, right? And so hospital at home is one option that we started to learn about very early on. But as we started to interact with emergency departments, because that was the location, right? We used to call that, or we still call that, the last exit before toll, right? It's the last opportunity you have to disrupt that high cost trajectory and also the potential dangers of that clinical trajectory. So we started to do a lot of work, and Bruce was involved with this, where we started engaging with the emergency medicine community and really heard loud and clear from them that they were ready, willing, and able to do different disposition options from the ED if they had them. Mm-hmm. So that's when we really started to look what is out there, what's available for clinicians to do something different. And we found there was very little. Now, a lot has changed in 5 years. I think back then there was maybe a handful, less than half a dozen of hospital at home operations, and very, very few what we call acute care at home, which may be something, not quite as intense as Bruce has described. Hospital at home is a wonderful option for a lot of people, but we started to also say, what are the other options that we can do? What are the other disruptors along the way? And we can talk some more about that in our work with the IHI of how we've started to engage home health agencies, which are in every community in the United States, emergency medical services, which are in every community in the United States. And how can we start to draw on these other resources in the community to develop the continuum of acute care responses? Years ago, I saw a slide that Bruce presented at a conference that really laid out that sort of continuum of care, all the way that starts at sort of a home-based primary care, right, on one continuum, or home health care aids or things that help seniors stay in their home, and building that intensity all the way up to the most intense, which is a hospital substitute, where you're basically, replicating hospital level care in the home, all of which has shown to be better for seniors. Really, older adults want to stay at home. They do better at home. Right. And, we're not discounting all hospitalizations or all ED visits. That's certainly the right place for a lot of situations and conditions. But we're really discovering year by year, right, month by month, the capabilities that can happen at home, especially technology enabled.
You're going to start to see the ability to put these models together from, personal care services to skilled home health care to home-based primary care to home-based palliative care to home-based primary care co-management models to ED at home and observation at home and hospital at home and rehabilitation at home, and organizing all of that into a fully baked home and community-based healthcare continuum.
Sure.
And what that's going to take is a ton of capital, because you have to develop a robust set of supply chain and logistics to support that. But you see that happening, right? Mm-hmm. Like today, Amazon announced that they're taking their employee-based care at a distance, and they're going to open that up to the whole country.
Oh, wow. I hadn't heard that yet.
That's a huge thing.
That is
a huge.
Hearing that, it begs the question, does this really save money? It sounds pretty expensive. Does it save money, and who realizes those savings?
So the answer is absolutely yes, it can save money. The devil is in the details of how you structure payment, right? So, if you think about the idea that hospital at home reduces hospital readmissions, reduces skilled nursing facility stays, that is true reduction in utilization. The what you hear in the concerns that you hear about hospital at home is that potentially it could just increase utilization without necessarily reducing costs, right? So, but I think a few things people tend to forget. Number one, if you can provide more acute care at home, you can actually not have to build hospitals, right? So in Australia, where hospital at home in Victoria State, Australia, so where Melbourne is, about 25 years ago, their health authority said, excuse me, we're going to pay for hospital at home at exactly the same rate we pay for hospital care.
Wow.
Kind of like what CMS did with the hospital-based waiver a few months back. And what their own health authority studied and reported out was that had they not done that, they would have had to have built another 500-bed hospital in Victoria, right? And it costs somewhere, depending on where you build a hospital in this country, it costs somewhere between $2 and $5 million per bed for a hospital construction, right? San Francisco, they need to be earthquake proof and a little cheaper here in Baltimore. But a 500-bed hospital at $2 million per bed, that's $1 billion.
Yeah.
And it's not only building it, but then it's all the ongoing fixed costs. It's, the pressure on management and leadership to fill those beds, right? Because if you don't have a head in the bed, then you're losing money.
Sure.
So you can, there's clear societal return on investment if you can avoid building more beds. You can reduce post-acute utilization. And there's a ton, you mentioned the statistic about the $1 trillion or so spent on hospital. There's a ton of money that's also spent on post-acute care. And if you can reduce that cost, then that's also cost savings. But the payment mechanisms have to be very carefully constructed. So it can absolutely save money.
Yeah, and the way that we've approached this at West Health is to really deeply understand incentives and alignment of incentives and saving money for who when you do these different types of models. So we sort of dug really deep into this and understanding that CMS is setting up payment demonstration models. ACOs is a big one, right? So if you, instead of paying for volume, like how many times you do a certain procedure or an admission, getting paid for it, how do you align organizations to deliver value and get paid for the value they deliver rather than just the volume that they deliver? As Bruce mentioned, that's something that has been a concern, that if you create a reimbursement for something, then you're incentivizing people to do more of that because they can get directly reimbursed for that. And while absolutely people need to get paid for the services that they deliver, we are really looking at, sort of that alignment. So we've started working mostly with risk-taking organizations, accountable care organizations being the top of the list, because they are incentivized to deliver the right amount of services, the highest quality of services that deliver the best outcomes for the lowest cost. So we find that sort of greases the skids, right? So we've got people lined up that are ready to do the right thing. And CMS is also committed to not having cost shifting to the beneficiaries, right? Okay. So we don't want the older adult to have to shoulder more of the cost. Right. So many of the waivers that they've delivered is that accountable care organizations taking on financial risk are allowed benefit enhancements that allow for waivers in, say, the patient copay for high value services that they receive. So that's just one example.
I'm dying to know, how do hospitals feel about this? Are they anti? Are they supportive? I think
you'll find different hospitals and different health systems are taking different views. I think that innovative health systems that have, leaders who are thinking out into the future and kind of understand where healthcare is moving towards, and at a national level, the current system is just not sustainable at a national economic level. And I think they do want to be parts of the solutions. Yeah. The challenge is change, right? So Amy's probably heard me talk before about the backward bicycle.
Right.
So Leanne, if you don't know that one, go on. Everyone's assignment tonight is to go onto YouTube and put into the search engine backward bicycle. And the short story is engineers built him a bicycle that's backwards. That is, when you turn the steering handles to the left, the wheel goes to the right. And he thought it would take him about 12 minutes to learn how to ride the new bicycle. And it took him 8 months, right? And he uses as a metaphor that you can understand or even want to change. But changing things that are very hardwired in a system is actually quite hard, right? Yeah. So, riding a bicycle is a very hardwired thing. You get on a bike, you're not thinking about it, you just go.
Muscle memory.
And hospitals and the health system that has been built over the last 80 or 100 years, a lot of things get hardwired. All of those things, from the path from office to ED to hospital, blah, blah, all of that stuff. All of the financial Excel sheets that are sitting in, hospital systems around the country as they evaluate new opportunities, all of those things. And, value-based care, which has really come on over the last 10 years, that's been starting to shift how they think about things. Yeah. But I think they're responding a bit to the fact that they understand that at some level, their business will be disrupted by the Amazons and, organizations that will do that. And they've seen other industries, large industries, go down with that. So they're not immune to that. And I think they understand that there may be better ways to use hospital beds and to serve patient needs. And you've seen that over the last few years, say, with hospital at home, where things that we never thought we would take care of at home are going to be taken care of at home and are being taken care of at home. Like a lot of there's tremendous interest in the oncology community around hospital at home. So instead of someone staying 35 days in a hospital for a bone marrow transplant, they spend 3, 4, 5 days in the hospital, and then they get the rest of the stuff done.
Better for everyone. Better for everyone.
Yeah. Right. If you're totally immunocompromised, why do you want to be in the biggest petri dish in the world full of bad organisms? Yeah. You're going to see all of those kinds of things happen. So the challenge, I think, for leadership is to figure out how can we integrate, how can we be part of the solution? How can we integrate these models, be part of the solution, not only for delivering care that many people want, but also helping the healthcare economy, and then think about the ability to repurpose labor and space in a way that maximizes the healthcare that we can provide for people.
Great.
And you've seen shifts like this happen. And you've also seen how that backward bicycle thing applies. So, the pandemic hits and everything moves to televideo.
Right.
It all happened. And, systems that had been dipping a toe in, maybe this will take us 5 years. In 2 weeks, they were up, or a month, they were up and going with it because it was life or death at that moment. And, change. And then pandemic starts to wind down just enough of a touch. We can start to bring people back to our clinics. I know in my own clinic, I'm back to full-time in-person clinic.
Yeah. Wow.
And quite honestly, I don't necessarily need to do that for all of my patients. I would love to be able to mix and match a little bit more and make it more convenient for them and all of those things. But that's sort of that backward bicycle going back to
pulling you back.
Regular bicycle, right? Because that's the familiar thing. That's what we know how to administer a hospital and an ED and a clinic and all of that. And I'm not being critical. It's just really just an observation, and it's hard to change.
Indeed.
But you're seeing big systems like Humana, for instance, is making a big push. They're trying to shift a lot of their stuff to the home.
Well, Amy, let's go back to you for a second. You mentioned West Health collaborated with the Institute for Healthcare Improvement to come up with some new innovative ways that address unplanned acute health events. You mentioned home health involvement. Tell me about that partnership and some of the success stories that have come out of it.
Sure. Well, if listeners are not familiar with the Institute for Healthcare Improvement, they are really the international leaders in process improvement and patient safety. And so they were just a natural partner for us as we approached this from a change perspective standpoint and process improvement. And we're starting our third collaboration with them where we bring together healthcare organizations, big and small, academic and otherwise, to work together in what we call learning and action networks. And we've adopted the model of improvement, and this really provides that rigorous sort of measures-based focus on lowering emergency visits, hospitalizations, and other associated costs. And we do this through teams engaging in rapid cycle tests of change that's really necessary to make that improvement. And our ultimate goal in the partnership is really that reduced utilization and developing cost-effective programs. And that's where I talked about, we were not prescriptive. This wasn't pick a model and let's, study this model. Others are doing that work and that's good to be done. But we really wanted to, sort of create that blue ocean for our teams to be able to try new things, to try out a rapid response from a home health agency, which is not typical for them. They usually do a start of care within a couple of days, post-acute. And we have home health agencies that are really trying to step up their game, provide a higher level of acuity and quicker so that patients can get transitioned out of emergency departments and start a home health episode the same day with, maybe upfront visits that are more intense a couple times a day for a few days.
Sure.
I mentioned EMS. We have teams that have partnered with community paramedics who, and we have a great success that happened actually during the pandemic with one of our partners at Mount Sinai. They, were getting probably 1 to 2 calls a day for their community paramedic referral to go out and see patients who were having an acute event. Again, not through the 911 system. So this was a rapid response EMS within sort of 60 minutes or so. Yeah. 1 to 2 calls a day went to 15 calls a day during the pandemic. And they increased their volume by almost 200%. So they really, offered a huge service during the pandemic. In fact, I think I have that they had 350 visits in all of 2019, and it was over 1,000 in 2020.
Wow.
And very few of those were needed a subsequent transport to the ED.
Okay.
They, in our collaboration with us, averted over 590 emergency department visits and 240 hospitalizations in 2020, which was
that's huge.
Which was really huge in the pandemic. The collaborative that we had together, we had 12 organizations that partnered with us in 2020. The pandemic was interesting because it sidelined some of our collaborators who had team members working on the collaborative, on these home-based acute care models who had to be redeployed to help their health system during the pandemic, where we had other collaborators that their programs were suddenly inundated with volume because hospitals didn't have beds. And so Mount Sinai is another good example with their hospital at home that they ended up being able to provide continuing hospitalization at home, and they were able to help offload the hospital to create capacity. And that was also a huge benefit. Yeah. But all together, our dozen collaborators averted over 1,200 ED visits and 600 hospitalization with the top level Medicare spending save of over $8 million. So it was very successful. We are launching actually next Wednesday, our next collaboration, where we're really diving in with a group of risk-based organizations, ACOs, to really understand the financial sustainability of these models. As Bruce mentioned, reimbursement for services is a big issue, especially if you're outside sort of the traditional, code-based, DRG-based model of Medicare payment. So this next collaborative is really understanding how do we get these, how do we sort of match the square peg with the round hole of a delivery model with a payment model. And so that's going to be the work of the coming year.
Yeah. So We've heard a lot from both of you about, players in this field, how these trajectories are being disrupted conceptually. And Amy, you just did a really nice job of laying out the financial impacts of these models too. I wonder if we can wrap up just with some final thoughts from both of you of what could we be doing at the policy level, or what should healthcare leaders be doing to keep this momentum going and to set the stage for a growth of at-home care? Amy, why don't we start with you?
Sure. So I think, what we really have learned in this past year is that the systems that we have in place to care for our older adults, just in general, have major flaws in them. And so I think from a policy level, I think all of this needs to be looked at. And, we certainly advocate for any models that can better serve seniors at a lower cost. And we support CMS's efforts. We believe that they need to listen to the providers who are taking on risk so that the payment models that they're demonstrating really yield sustainable and scalable solutions that really serve seniors.
Yeah, I agree with what Amy has said. I think that, one of the things that leaders and payers can start to do is to just start to wrap their minds around the fact that home-based care is actually real care. Mm-hmm. It's real medical care, it's real social care, it's real personal care. And that for some reason, I would love to hear what Amy thinks about this. For some reason, it feels like home-based care, to overcome the square peg round hole thing, has always had to prove itself again and again and again, whereas traditional models, this is what we do. We don't have to prove anything. I have never once seen a randomized controlled trial of ICU care. Never one. And there are probably now 60 or 70 randomized controlled trials of hospital at home. Right. There are multiple trials, multiple good clinical trials, well-controlled observational studies on home-based primary care. And yet everyone just keeps coming back, where is the evidence? Where is the evidence? And I think most of the time that question for evidence is really a smokescreen that we're on the bicycle that we're on and we don't want to change. Yeah. And I think that's a big part of it. So I think if health system leaders don't want to, end up like U.S. Steel being disrupted from below, then I think they need to learn and start to get socialized on care delivery that is not their traditional bread and butter. Because if they don't, other people are going to disrupt them, and they'd be much better off disrupting themselves.
Well, thank you so much, Bruce and Amy, for being with us today on Leverage. And thanks, everyone, for listening. We'll keep an eye on how acute hospital care at home and more evolves. Take good care.